بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. My presentation today about anomalous pulmonary venous return. I will present short review about this anomaly and I will present two case presentation. My name is محمد pediatric cardiology consultant and professor of pediatric and pediatric cardiology at Mansoura University Children's Hospital. بسم الله الرحمن الرحيم. Anomalous venous return is a rare congenital heart disease. In this malformation, the pulmonary veins do not return to the left atrium. As we know that there is 4 pulmonary veins, 2 from the right lung and 2 from the left lung, and the 4 pulmonary veins usually join the left atrium as a pulmonary venous return. If these 4 pulmonary veins fail to join the left atrium, so it will be total anomalous pulmonary venous return or total anomalous pulmonary venous connection. If 1 up to 3 of the pulmonary veins fail to join the left atrium and drain anomalously to somewhere else, it will be termed as partial anomalous pulmonary venous return. The types of total anomalous pulmonary venous connection. I will say the types and then I will describe the hemodynamics. We have 4 types of total anomalous pulmonary venous return. Type 1, which is a supracardiac type. Type 2 is the cardiac type. Type 3 is the infracardiac type. Type 4 is the mixed type. All types of total anomalous pulmonary venous return are considered left to right shunt. Left to right shunt. So whatever the type, it is left to right at the end. It behaves like hemodynamically like left to right shunt. So there is volume load on the right side, and all cases or all anomalies or all types should have obligatory right to left shunt across the atrial level, and this is needed for survival, as the blood, the whole pulmonary venous blood comes back to the right side of the heart, so the blood should go also to the left side of the heart. So this necessitates an atrial defect, either BFO or atrial septal defect, which represents the inflow to the left side of the heart. So the blood will move from the right atrium through the ASD or BFO to the left atrium, then to the left ventricle, then to the aorta. So the cardiac output depend on this atrial defect. So there is obligatory right to left shunt at the atrial level, and the total anomalous itself is left to right shunt. So left to right shunt by anomalous venous return and right to left shunt intracardiac through the atrial septal defect. Of course, there is mixing, and there is the mixing occur here in the right atrium, which is a mixing between the oxygenated blood coming from the lung and the venous or deoxygenated blood coming from the systemic venous return. Let's show type by type and describe the anatomy. Some pop-up message come anyway. In supracardiac type, it is the most common type. It represents 52% of the cases, and the pulmonary veins here, when you see, this is the pulmonary veins displayed in red color. I'm sorry, touch screen usually do like this. The 4 pulmonary veins join together, 2 from the right, 2 from the left, and make a confluence here. Make a confluence, and from this confluence ascending vertical vein, which is displayed in red color here, ascending, and you can see, follow the arrow, ascending vertical vein. This ascending vertical vein usually join the innominate vein and sometimes go to the right side and join the superior vena cava. So the pulmonary veins drain into this sac, so ascend or course superiorly in the vertical vein and drain the innominate vein which end in the superior vena cava and the right side of the heart. So this is left to right shunt. Sometimes this vertical vein may be obstructed if it is course between a bronchus and the pulmonary artery, or it's going to the right side and the course for a long distance and join directly the superior vena cava. So this is type 1 or supracardiac type. Cardiac type. In this type, this is the second common type, which represents 30%. And in this anomaly, usually the pulmonary vein join the heart itself. These pulmonary veins either join the right atrium itself, or it join the coronary sinus, which it terminates into the right atrium. The coronary sinus, by the way, it is a venous drainage of the heart, and it usually course in the posterior wall of the left atrium. And sometimes the four pulmonary veins join this coronary sinus, and then which drain by itself also to the right atrium. So the end point is the right atrium. Or sometimes these pulmonary veins join the right atrium directly, but usually coronary sinus connection is much more common than the right atrial connection. The infracardiac type usually represent 12% of cases, and in this type, and as we see before the supracardiac type, it is the same exactly, but the vertical vein, instead of going superior, here in this anomaly it's going inferiorly, and usually has a long course, and it can pass through the esophageal hiatus and through the diaphragm and join the inferior vena cava, sometimes join the hepatic veins, sometimes join the portal circulation. So this anomaly or this vertical vein is liable more for obstruction of this vessel, which represents the emergency. We will talk about this later in this lecture. So this is the infracardiac type. This type usually common with asplenia syndrome or polysplenia syndrome, which is represented heterotaxy syndrome. The last type is type 4, or we call it mixed type. Usually it's mixed between type 1 and type 3, sometimes type 1 and type 2. And like in this image, there is the right side, the right pulmonary veins join the right atrium directly, and the left pulmonary vein join the innominate vein. Sometimes the right pulmonary veins join the superior vena cava, and left pulmonary veins join the innominate vein. So mixed type like this, so it's a mix of both type. Let's pause this. So as we give a brief about the pathophysiology before, so we have to in the total annulus pulmonary venous return, there is left to right, then right to left. So usually the pathophysiology mainly depend on the nature of the anomaly. Either it is total or it's partial, it is supracardiac, it's infracardiac, it is with obstructed vessel or non-obstructed vessel, the degree of mixing inside the heart, the presence of atrial defect or patent foramen ovale, is it restrictive, is it wide enough, presence of absence of obstruction to the pulmonary venous flow, the compliance of left ventricular size, and its compliance, also the left atrial size, because usually it's very common to find a sort of smaller left side of the heart with this kind of the anomaly, because usually it's underdeveloped prenatally, because there is no much flow going into the left side, so this left side usually underdeveloped. So this is the factor. These four factors determine the clinical presentation, determine the pathophysiology, determine even the way of the therapy or the intervention or the management for the patient. In total anomalous pulmonary venous return, as we said before, all systemic and pulmonary venous return come to the right side of the heart, so it's large left to right shunt, like NSD. And two to maintain the cardiac output and the patient survival, we need obligatory, again and again and again, we need obligatory right to left intracardiac shunt across the ASD. So if this patient has a restrictive BFO or small ASD and it's not sufficient to maintain the cardiac output, so this patient is eligible for urgent septostomy, like in cases of transposition of the great arteries. The indication here is to maintain the cardiac output, but in transposition of the great arteries, the indication is to improve the mixing and improve the systemic arterial oxygen saturation. In cases of obstruction, which is represent the true cardiac emergency, this is the main or the true cardiac emergency in newborn. Of course, after cyanotic heart disease or duct-dependent lesion in the past, it was the first emergency, but after the era of prostaglandin and the wide use of prostaglandin now, so it came as a second emergency after this total anomalous with obstruction. So imagine the blood is coming from the lung and should go to the left side of the heart. Anyway, it's not going to the left side, but going to the right side. Whatever. There is obstruction. So there is a very high back pressure on the lung. This will increase the pulmonary pressure, increase the pulmonary hypertension. So this patient immediately will have a pulmonary congestion and severe pulmonary edema, and this will be severe heart failure for the patient. So usually this is reflected with severe distress. You are in need of high oxygen to maintain oxygenation. You are increasing your ventilator parameter. You don't have improvement of oxygenation in spite of this, of your strategy. You cannot even improve the oxygenation of the patient. So this obstruction in the vertical vein, usually it's common with the infracardiac type more than the supracardiac type, although it can occur with this with both type, but it's common with infra than supracardiac type. So at the end, this will increase pulmonary hypertension, will make a burden on the right side of the heart, and it cause severe pulmonary hypertension and right ventricular pressure overload, right ventricular hypertrophy, right ventricular then right ventricular dilatation, then failure. So usually the presentation of total anomalous pulmonary venous return, it's usually present in the neonatal age, with if there is severe obstruction, the patient is severely cyanotic, severe respiratory distress, even within a few minutes, even or within an hour, even after birth. So there is severe tachycardia, severe hypotension due to low cardiac output, and also there is severe pulmonary manifestation and severe pulmonary edema. If there is no obstruction, usually the symptom is less acute and mild symptom even at birth, sometimes buzzed unnoticed by the neonatologist. Symptom and sign of increased pulmonary blood flow, we said it is a left to right shunt, so you have element of pulmonary plethora, and this make the patient little bit tachypnic and distressed. With the growth, maybe in the first or second months of life, usually this patient shows failure to thrive, tachypnea, diaphoresis, interrupted feeding, difficulties in feeding, like this. And usually cyanosis is mild degree of cyanosis, but with coronoscopy, these people or this patient developed severe pulmonary hypertension. Diagnosis of total anomalous venous return, usually by imaging study. It's just radiography. It can give you not a clue, but it can give you if it is severe obstruction, there is pulmonary edema, pulmonary congestion, pulmonary pressure, but it's difficult to give you idea about the specific lesion. Also, of course, there is snowman appearance in X-ray, but usually it needs sometimes and difficult to be seen in newborn. Echocardiography, usually it's the gold standard. It is very good tool. I can say very good tool for diagnosis of total anomalous venous return. It can detect almost 100% of cases, especially total anomalous, especially supra and infracardiac type. Maybe echocardiography sometimes is difficult to see the cardiac type, not difficult, but can give a good suggestion about the cardiac type and mixed type. But it is usually very clear for supracardiac and infracardiac type by echocardiography. Multi-slice CT angiography, actually it is a modality of a choice now, and I will show some images here about some of my cases. And usually it is the investigation of a choice or the modality of a choice, as we said. It should be done even if the echo give you a good. Usually the surgeon insisted to have this kind of modality. Cardiac catheterization, actually its role the diagnostic test for or diagnostic imaging for total anomalous pulmonary venous now become not obsolete, but the role become much more limited. It may be indicated for hemodynamic study. Sometimes it may be used as an emergency intervention with some cases of obstruction to just palliate the obstruction and dilate the obstruction until the surgery become available. But actually, after the era of CT angiography, the role of cardiac catheterization as an imaging study for diagnosis of total anomalous pulmonary venous return become limited. This is some images of different patients in their left corner. This one, there is the four pulmonary veins forming a sac here behind the heart, and there is ascending vertical vessels which is obstructed in its middle part because it's compressed between the bronchus and between the left bronchus and right bronchus and right pulmonary artery, and they call it usually pulmonary vascular vice or pulmonary venous vice. The other one, they has anomalous venous return directly here to the back of the superior vena cava. Maybe if you can concentrate, it may need to concentrate and focus to see this anomalies. This is supracardiac type. The above image also supracardiac type. Let's see, this is infracardiac type. You can see in the left corner, our left side, this one is, we call it pulmonary tree. This is the same anomaly, but two different patients. The four pulmonary veins from the right side, from the left side, connected together, and from which there is descending vertical vein, and this vertical vein going down to join usually the portal circulation and sometimes join the IVC or inferior vena cava below the diaphragm, and also usually liable to the obstruction at its terminal part, or sometimes obstructed during its course from the esophageal hiatus or through the diaphragm. Medical and interventional management. Usually the non-obstructed total anomalous pulmonary venous return sometimes buzzed unnoticed in the neonatal period or in the first few days after birth. And as long as the pulmonary vascular resistance started to decrease, so the volume of left to right shunt is increased. So usually this patient has volume loaded right ventricle and become congested, and this child usually need some diuretics until stabilized, decrease the load of the left side, and these babies, once diagnosed, should be referred to the surgery. But also, if it is discovered or the patient manifestation was severe during the neonatal period, especially if the atrial communication is restricted or restrictive or small, so the interventional cardiologist usually do balloon atrial septostomy to improve the flow of the blood from the right ventricle to the from the right atrium to the left atrium to the left ventricle to increase the cardiac output, and also this will promote the growth of the left side as a rehabilitation of the left side for the patient to be operable, because if the left side is small, it's usually difficult to drain these vessels again to the left side. Sometimes the left side cannot accommodate all of these veins immediately after surgery, and the patient go into left side heart failure. So if the patient discovered at the neonatal period and this patient needs septostomy, septostomy will be done immediately. And usually the optimum time for the surgery, usually in the first early infancy or the first few months, second, third, or fourth months even. Anyway, before development of severe pulmonary hypertension. Type. What if it is obstructed? If it is obstructed total anomalous pulmonary venous return, as we said before, it is the only true surgical emergency. يعني the neonatologist should insist to give the patient to the surgeon. No way. He has to take the patient to the OR, even 12 midnight. So, if there is obstructed form, immediately you need intubation, you need positive pressure ventilation, you need high oxygenation, you need to correct the metabolic acidosis, the patient in severe pulmonary edema, severe cardiogenic shock. Usually these medical measures difficult to actually to control the patient because there is actually mechanical obstruction of the flow coming from the lung. Usually the prostaglandin has no definite role. Balloon septostomy sometimes improve the situation, but it's not the management. As I said before, I will show it later. Now we can do vertical vein ballooning or vertical vein even stenting. If the surgery is not available, the interventional cardiologist can take the patient to the cath lab and dilate the stenotic part of the pulmonary veins and even put a stent as a temporary. It's not a permanent, of course. It's a temporary or palliative procedure until the surgery become available. Sometimes it's necessitated to use ECMO also to stabilize the patient until the surgery become available. So obstructive total anomalous pulmonary venous return, it is true surgical emergency within the field of congenital heart disease. Actually, it is one of my cases. I did here ballooning of the vertical vein. It was supracardiac type, and there was obstruction in its middle part, and we need to stabilize the patient little, maybe 12 hours at least before surgery, and improve the oxygenation. We take the patient to the cath lab and did ballooning. But I'm sorry, the videos, maybe I'm presenting through my mobile, so it's difficult to run the videos here. The other types of anomalous venous return is partial type. We said if 1 to 3 of the pulmonary veins fails to drain to the left atrium and drain somewhere else, it's partial anomalous pulmonary venous return or partial anomalous connection. Also, it's rare type, the rare types of anomalous connection, and usually this is found in 0.4 to 0.7% of postpartum extremities. Also, sometimes the diagnosis become late, even in the third, fourth, fifth decades even of life, if it is 1 or 2 vessels. Also, it classified into 4 types: supracardiac, cardiac, infracardiac, and mixed type. Supracardiac type, the most common site of the partial anomalous in the right superior vena cava. Usually 1 or 2 vessels of the right lung join the superior vena cava, and the other 2 left veins join the left atrium normally. So this is partial type. Sometimes persistent left superior vena cava. Some people have another accessory superior vena cava on the left side, and usually this superior vena cava drain to the coronary sinus. And this is normal finding in some people. Sometimes the left, as the right pulmonary veins join the right superior vena cava, also the left pulmonary veins can join the left superior vena cava, and the right pulmonary veins join normally to the left atrium. Sometimes these vessels, or pulmonary vessels, pulmonary veins, join the brachiocephalic or innominate vein. So they can join any vein in the head and the neck. which is common, right superior vena cava, persistent left superior vena cava, the brachiocephalic vein, which represents the most biggest or the bigger vein in the head and neck. Cardiac type, it could be to the right atrium, it could be to the coronary sinus, infracardiac to the portal vein, hepatic veins, inferior vena cava, which is scimitar syndrome is the best example of this. Usually one of the pulmonary veins of the right lower pulmonary veins usually don't connect to the left atrium and usually course inferiorly besides the right border of the heart and through the diaphragm and join the inferior vena cava. Mixed type, it could be a mix of these above anomalies. Presentation, usually the presentation depend on the extent of the anomalies. يعني one vessels is different than three vessels. Usually one vessels can pass asymptomatic and even sometimes discover incidentally when the patient usually يعني in adult age, third, fourth, even fifth decades due to any cardiac check-up or something like this or any imaging. It can be discovered incidentally. Pulmonary manifestation usually increased with the number of vessels and it represents left to right shunts. I remember one patient, he was 30 plus and he referred to me as he has ASD because he has right ventricular dilatation, and this patient actually diagnosed when he is 35 years old as a partial anomalous pulmonary venous return of the right pulmonary veins to the superior vena cava. Sometimes desaturation with the development of pulmonary hypertension and right to left shunt across BFO or ASD, small ASD, right side heart failure and systemic congestion, it happens, or cyanosis with severe irreversible pulmonary hypertension, usually with age, and also decreased exercise intolerance due to right ventricular failure. The diagnosis also, usually the echocardiography usually gives good suggestion, but as we said with total anomalous pulmonary venous return, the CT is a modality of a choice in this patient, and the cardiac MRI also is one of the best tools for this kind, especially in adult. X-ray usually with scimitar syndrome can give a good diagnosis, even a spot diagnosis, but with other pulmonary veins it give actually no clue. This is some echo image. Maybe it's actually video clips, but it will not move. But anyway, the first image to the right here is the drainage to the superior vena cava. The other one vertical venous obstruction, and the other one is infracardiac type. Here there is pulmonary veins connected to the right superior vena cava, and the other one is connected to the innominate vein. This is chest radiography in scimitar syndrome. You can see the right lung hypoplasia, and you can see the scimitar vessel, and you can see elevated diaphragm due to right lung hypoplasia with some dextroposition of the heart. And this cardiac cast here in scimitar syndrome can give you good delineation of the scimitar vessel, and also it has usually hemodynamic indication more than imaging indication. So the surgery, the only way for this kind of anomaly is a surgery, and usually surgery is give good result. Nowadays surgery has a low risk of morbidity and mortality, and this usually decreased from 15.8% in 1984 down to 0% recently, and usually the survival rate is very, very high. But sometimes it may happen some complication like post-repair pulmonary venous stenosis, and the patient necessitated another surgery for batch augmentation of the pulmonary veins, pulmonary venous stenosis, arrhythmia like sinus node dysfunction, sinus bradycardia, sinus pause, and ventricular arrhythmia, usually uncommon. But the prognosis anyway is good. But the factor usually affects the prognosis is the degree of pulmonary venous obstruction. Is this patient has obstruction or no? Any associated defect, like in patient with isomerism, usually carry bad prognosis. Unobstructed usually has mortality of 4% as a late mortality, and the early percent 10%. Obstructed pulmonary venous return is a little high mortality, 17 early percent, early 17%, and late mortality 11%. Total anomalous with associated anomalies other than BDA and other than ASD and BDA, because this is part of the anomaly, actually not considered the association. 14% as early morbidity and 18% as late mortality. 14% as early mortality and 18% as a late mortality. But partial anomalous pulmonary virus return usually very good prognosis and very good survival rate. I will present quickly two cases, one of supracardiac type and the other one is infracardiac type. This patient, it was a term baby boy, 33 weeks, born by cesarean section due to breech presentation. His birth weight was 3.27. At the age of 1 hour, the baby developed cyanosis with saturation of 75%. He was transferred to NICU and intubated immediately. He was before intubation, he was crying, but he was cyanotic, severely cyanotic. His vital signs was stable, 70% on 100% of FI2. Chest was bilateral, good bilateral air entry. His heart rate, there is systolic murmur. The abdomen was soft, no organomegaly. Neurologically, his normal tone. This is the X-ray of the patient, showed some cardiomegaly, and there is hazy lungs or ground glass appearance of both lung field. And I'm sorry, the echo videos will not move. Anyway, the echo of this patient suggested infracardiac type pulmonary venous return without obstruction. And this patient, this is the pulmonary veins at the back of the heart joined together and making descending vertical vein, and this vertical vein join the portal circulation. The patient was stabilized for a while, and the surgery decided to repair the patient after a week from the delivery of the patient, and this patient was operated, and this is the X-ray on discharge of the patient. The both lung fields become much more clear, and the patient survived. And the patient now is 5 years old. Case 2, also term female baby, 3.2 kilogram, born through normal delivery, and she was in the regular nursery post delivery. The baby was well after birth and started breastfeeding. A few hours, almost 12 hours, the baby developed respiratory distress, then developed immediately severe cyanosis, and down to 70, baby transferred to NICU, ventilated, intubated, given high FI2. The patient is not dysmorphic. Chest examination was equal air entry. There is no any adventitious sound. Cardiovascular, there is no murmur or active pericardium. The rest of examination was normal, good pulses, warm extremities. The X-ray of this patient, the patient started to deteriorate quickly, more and more, and the lung become much more congested and wet. And this is a image from the CT of the patient later on. And this patient diagnosed as supracardiac type with obstruction. This is the supracardiac type, and this is a vessel, ascending vertical vessel or vertical vein was obstructed here between the right pulmonary artery and right bronchus, and obstructed, and they make severe pulmonary edema for this patient. This patient was taken immediately to the OR and operated immediately, and this patient was survived. This is the X-ray for the patient after discharge. Before discharge, the lung become very good. So this is our experience in the last maybe 7 years, up to only 2000 from 2007 until 2014. I think still some cases after 2014, but maybe I didn't update these slides. Anyway, we operate 7 cases of type 1, 1 type 2, and 1 case of type 3. There is no any operative morbidity, no operative mortality, and it was good long-term follow-up up to 5 years. without any reported morbidity and mortality, and this is two of my patient. Thank you. Thank you.